This patient was referred to me for endodontic retreatment of tooth number 13. According to the patient, the root canal was done about 4 to 5 years ago in India, along with the crown. For the past few weeks, tooth has been hurting him, waking him up in the middle of the night, and he has to take pain medication. So finally, he went and saw his dentist, and his dentist took a CBCT and determined that tooth number 13 was abscessed and referred him to us. Again, this is one of those situations where I don't understand the value of a CBCT versus just a simple PA. You can see on my PA, I definitely see a periapical lucency. Why get a CBCT? Why expose the patient to extra radiation? Also, extra charge. Why do that when one PA and right there? Anyways, it is what it is. Let's not focus on that too much. But anyways, so we discuss options with the patient. Redo the root canal, 80% chance of success, 20% chance of failure, or if the patient is one of those patients who wants 100% guarantee, I don't know what in life has a 100% guarantee other than taxes and death, then patient can go ahead and extract the tooth. Patient said, no, I'm completely okay with 80% success rate. 80% success rate, by the way, is a pretty high success rate. So patient wanted to save the tooth, so that's what we did. Went through the crown, and as I went through the crown, I'm under the microscope. I removed the gutta percha with my endo explorer from the coronal part of the tooth out of the canal orifice. And the distal margin of the crown, I noticed, was placed on gutta percha. The distal margin of the crown, the entire distal margin was placed on gutta percha. Okay. So, he's going to need a new crown, unfortunately. And on top of that, of course, we're redoing the root canal. I don't do crowns, so that would be his general dentist. So, went ahead, removed the gutta percha. I used chloroform and hand files, removed the gutta percha. When I see a periapical lucency that's lateral to the root of the tooth, I'm always striving for a lateral canal right into that lesion. That's what I'm shooting for. In most cases, I get that. Some cases, I don't. But my goal is to clean that lateral, because as you can see, the periapical lucency is not centered around the root of the tooth there. And take a look. 6% sodium hypochlorite, of course, and take a look. And here it is. I was able to get that lateral right into the lesion there. Look, one canal bifurcates apically. You can see the bifurcation, and then a big lateral right into that lateral lesion. As you can see, everything went beautifully. As I said, chloroform to remove the gutta percha and hand files. Then one rinse with isopropyl alcohol. Isopropyl alcohol, kind of, I want to call it coagulation. Coagulates the gutta percha and chloroform mixture. Turns them into clumps, and then you can irrigate them out or use your files and just brush the canals with your files, or brush the canal with your files and remove the clumped up mixture of gutta percha and chloroform. And then I switched to 6% sodium hypochlorite. In this case, I use sonic and ultrasonic activation as well, and warm vertical obturation with gutta-percha and AH plus sealer to obturate the canal three-dimensionally, and as you can see, this is the result. So everything went great, as you can see. We went ahead and temporized the tooth and referred the patient back to his dentist for the permanent restoration. As I said, the distal part, I cleaned and removed as much of the gutta-percha as I could using ultrasonics, but definitely patient will need a new crown. This old crown needs to be removed, gutta-percha removed from the margin, distal margin there, and then tooth built up and a new crown placed. I made sure that my cavity blocked and sealed that distal margin, so there is no coronal leakage until the patient goes to his dentist in a couple of days for the permanent restoration.